Aloha, everyone. So I was excited to hear. I didn't find out till yesterday this is a Hawaiian theme, but I got my shirt on, and luckily I have about 20 of these. So if you like Hawaiian shirts, let me give you a tip. January, go to Pine Bluff to the Dillard's outlet there. They have these shirts, and Tommy Bahama is the brand that I like. They're like usually $125 for $25. So that is I go shopping once a year, but that is. So yeah, I'm excited to be here. There's a new program. It's called The Guiding an Improved Dementia Experience. That's the name of it, okay? So this is from the government. This is from CMS, and right now we could probably talk about what's going on in the government, but I think this is maybe one good thing that the government has done recently. So I want to talk about that. And I'm with Arkansas Palliative Care. That's my group. We take care of patients, and a lot of dementia patients. We take care of them in ALFs and actually do home visits. I take care of dementia patients at home. Myself, nurse practitioners go out to the home, especially for those patients who have a difficult. I think there was a question earlier about getting into the doctor and getting a diagnosis. We do that. We'll go out and make the diagnosis if we need to, and come to your home. But what I'm going to do now is lay the framework of why we need a program called The Guide, and tell you why the government thought it was going to be a good idea to offer this new benefit, okay? So I'm just going to give some background history first. So, here's the facts. I'm not going to go through all of these, but as we all know, y'all know more than anybody. Y'all have firsthand experience. Dementia is a tough disease. And you can read all these sort of statistics, but I think a few things that are like to mention here is right here. Among people age 70 or older, 61 of those with Alzheimer's dementia are expected to die before 80 versus 30%. So you see this here. If you're over 65, you got to have almost a 10% chance of having dementia. So it's a pretty high rate. We're seeing this more, and as the baby boomer is getting into this age group and getting older, we're going to see more dementia. There's a lot of burden. It's the 12th most burdensome disease. Y'all, I'm not telling y'all anything you don't know. Y'all deal with it. How many are caregivers here? Pretty much everybody, right? Right, so y'all know from the caregiver, not just a burden for a patient, it's burdensome for you, right? It's a tough, tough disease. Here's the interesting thing. 75% of people living in nursing home over 80, if you have dementia, there's a 75% chance. If you don't have dementia, there's only a 4% chance. So most of the patients who are in a nursing home with dementia, 80 years old, that's a huge disparity, 75 versus 4%. In this program we're talked about, the main design was, can we keep people in their homes longer? We may not help push them back years or never, but what if we could keep people in their home 6 more months? Another year. Delay that time. So that's one of the reasons, the idea is we want to try to keep people aging at home. Nobody wants to go, let's be honest, nobody really wants to go to the nursing home if they don't have to. It's a great service when you need it, but you want to be at home. You don't want to be in the hospital. You don't want to be anywhere else but your home. 40% of patients with Alzheimer's disease spend it in the end stages, those stages where they're incontinent, they can't walk, they can't talk. So you may have a diagnosis of Alzheimer's for 10 years, let's say. If it's 10 years, you're going to spend 4 years of that in that very advanced stage. Once again, we're talking about dying in the nursing home. Patients with dementia in the nursing home, 66% will die in the nursing home versus anybody else. If cancer, it's a 20% chance, 28% with other diagnoses. This is going back to, let's be at home. Let's take care of patients where they want to be with their family. All right, so this is it right here. In America today, there are 6.9 million people with Alzheimer's dementia. Now think about it. Arkansas has 3 million people here. You take Arkansas, double it, and add an extra million. That's how many people today have Alzheimer's dementia. That's a lot of people, okay? And that number is not flattening out. You can see here in 16 years, that number is going to be 11.2 million. That's almost double what it is now. You go to 2015, it's here. And these are different age groups. Right now, the majority of these patients are in that 75 to 84, but as we get older and we get out this way, that 85 group that has dementia is going to be the group. So this number is growing. It's an uphill climb. We're moving. This is not flattening, okay? You know, some of the great things, as Dr. Peppinger just said, some great drugs are out there that may alter the course of a lot of things, okay? But as of today, this is what we're going to expect in the next couple years. And we call this the silver tsunami, right? You wish I had hair. I don't have, well, I mean, it's kind of silver, right? It's getting a little silver there. But we see this wave of patients with dementia. And it's a tidal wave, and I'll be honest with you, it's a little scary because we don't know if the healthcare system, like you said, trying to get to the doctor, right? Do we have a healthcare system that can take care of these patients, right? I worry we may not. I mean, I think it's difficult today with 6.9 million. 16 years from now, we're going to have, 12 million. I don't know. I don't know if the workforce, we're going to have enough doctors, nurses, great groups, and all these people here today serve you from hospice and, give an Academy Award to those two people that just did a good job. I like that conversation, so good job. But I don't know if we have that workforce that's going to be able to take care of them. We're hoping we are, but a part of this guide program is to say, hey, what else can we do? What other resources can we put? Caregivers, you guys, right? It's tough, right? It's a tough job. Raise your hand if you feel like you have all the resources you need to take care of your loved one, that you have everything you need. Anybody? I don't think so, right? We don't. I don't think y'all know that more than anyone. You do not. There's something lacking. You can't get transportation. You got to get pull-ups. It's expensive. There's a lot of things. And really, I'll be honest with you, our healthcare system's really good at taking care of diabetes, high blood pressure. But this disease alone has its own very specific problems. And our healthcare system's not really great at addressing those problems, like transportation. Medicare doesn't pay unless you go and you're dying and you go to the emergency room, but just to go to the doctor, or if you need to go to physical therapy, that's going to come out of your pocket. It's going to be out of your pocket many times. So, we got 11 million caregivers in the United States. That roughly, if we said the minimum wage, and we're talking about a minimum wage here, that's roughly $350 billion worth of care. I read somewhere that if you look at all the McDonald's payroll, their payroll is like $300 billion. So if we were McDonald's, we are bigger than McDonald's as far as a payroll. Except, guess what? You're not getting paid, right? This is unreimbursed time. This is your time, right? You're not getting a check for that. But that's what we estimate. If you were getting a check, that's what it would be. Most of those caregivers live with them. So who all lives with their loved one they take care of? Right. That's a whole new thing, right? That's a whole different, it's a dynamic. It's not like you can leave, right? It's not an 8 to 5 job. It's 2 o'clock in the morning. It's 4 o'clock in the morning. It's not that kind of job. 65 and older. I'm not going to ask who's 65 and older. I know better. But roughly a third of people that are caregivers are 65 and older. And guess what? When you get 65, your health starts going down. I mean, 2 weeks I turned 55. And I don't do what I used to do. And I know it can be tough. I can't imagine what 65 may also be like. But here you are at 65 years old, a third of them, you're taking your time out to take care of your loved ones. And here's the interesting thing. You ever heard of the sandwich generation? Approximately a quarter of people are taking care of their children and their parents, right? So you got it on both ends. You're still trying to take care of your kids, okay, and you're trying to take care of your parents, which is, I've raised 4 kids. It is not easy, right? It is not an easy job to raise 4 kids. But I couldn't imagine trying to do that and also take care of someone else that's there. All right, and like 10% are caregivers. So when we look at how caregivers do compared to other caregivers. So if we take dementia caregivers, people take care of dementia, and we look at other caregivers. Say you're a caregiver for somebody with heart failure or cancer. What's the difference? And I'm not going to go through each one of these, but I think a couple things to note right here. Feeding. Other caregivers, only about 20% of those actually have to feed their loved ones, where in dementia, it's 33%. I think this is the big one, incontinence. If you're a regular caregiver, you may have to deal with this in about 12% of the time, but when you're dealing with dementia, that's 32% of the time, a third of the time, which is tough, right? You got to get the pull-ups, and somebody said, it's hard to get those things. They're expensive, and then make sure they're dry, because if you don't do it right, it can lead to infections and skin breakdown. So taking care of incontinent patients is very important, and doing it right, and it does take time. It does take time to do that. So there is a difference between dementia caregivers and caregivers for other type of diagnoses, and it's much, much more burdensome. Look at work. How many people actually still work and have a job here? Anybody? Yeah, so a lot of times what happens, you're going to work during the day and you come home and you're a caregiver, but you can see from a work standpoint, about half the people, if you look at people with just caregivers of other people, so we're looking at caregivers, so we're looking at all caregivers, but we're looking at groups from dementia patients and other caregivers, about half of that group, the double the rate that turned down a promotion. They didn't take that promotion to move up their career because their challenges that they were having as a caregiver was not going to allow them to do that. I mean, that's an economic impact on that person, right? They said, no, I'd love to be whatever, the manager, or move up in this organization, but I can't. And that's going to affect you downline. You may not get that promotion coming down. Another one, big one, lost benefits. Man, that's huge. You lose benefits. That's almost triple the amount of lost benefits, triple the amount of lost benefits. So even though this is an emotional experience, this is also economic and financial devastation for a lot of folks. If we look at, once again, other caregiver diseases, I'm going to point this out. This line here is the patients with Alzheimer's disease and other types of diseases. But look here, dealing with mental health problems, 41% versus 16%. Suffer depression, 40% of caregivers in this study suffer from depression versus 17%, right? Difficulty with medical tasks, that's double. So you can see that all of these things, caregivers for dementia patients have a lot more issues a lot of times than you do with other types. Percentage of caregivers who report high to very high stress levels, 59% of caregivers. Who would say that? Who would say they're in that group? Yeah? Who would say they have physical stress of caregiving? Who would say that? Right. And sometimes, this can be worse, right? I mean, a lot of times you can get rest, and just like they said, hospice offers respite care, gives you time to get rest. But I'll be honest with you, I think when patients go into respite care and you get a break, you kind of get the physical part of it. I don't know if that emotional part goes away, right? You're still worried, are they all right? They're not here, So even though that's a great thing, and I truly believe respite care is a necessary thing, because this is taking care of a dementia patient. It's not a sprint. It is a marathon. You have to pace yourself. You have to get rest. So other things, increased depression, decrease in social networks, right? Maybe you can't go to church like you want because you can't get there. You can't find anybody. So your social networks. And one of the big things in America, doctors are writing prescriptions for increased socialization. We have found loneliness is actually becoming a diagnosis, right? And doctors are actually selling, you need to be more social. There's a push that loneliness is causing more disease, causing more problems and healthcare problems, because before you were going to church, you were going to your bowling league, or you were doing these things. But a lot of times I think caregivers feel isolated. They're spending so much time that they don't have time to do those things, and that's not good. You really still need to try to do that if you can. They're the sole caregiver. They lose 3 hours of sleep a week. Who thinks that's low? I think that's low, right? 3 hours, right? What would y'all say? More like 12 hours maybe, or I don't know. But that number seems awful low to me. So But still, losing sleep. I don't know if y'all, if I don't get my sleep, I am grouchy. Ask my wife, Carolyn, talk to her. And they forgo health visits. They're not going to the doctor as often, right? They're not getting colonoscopies or mammograms and all these other things that we need to do, and increased visits. So, talk a little bit about the history of Alzheimer's. So in 1906, this is Dr. Alzheimer's. That's where the name comes from, Adolf Alzheimer's. This was his very first patient. Her name was Auguste Dieter. This is in Germany. And so he'd been taking care of her in the hospital, and when she died, he took a sample of her brain and saw all the manifestations of what Alzheimer's, the neurofibrillary tangles, all those things. And from there, we got the diagnosis of Alzheimer's, a specific disease. It comes from Dr. Alzheimer's. Now, bring it to 2024. We're at 118 years later. Dr. Peppinger just talked about these new drugs, right? That's very exciting, guys, because I didn't get to hear his whole talk, but it is the first time we've actually had a drug that can alter the course. All the other drugs we had deal with behaviors, but doesn't necessarily alter the course of Alzheimer's. So now we've got one drug and a couple that are in the pipeline that we can do that actually changes the trajectory and slow that disease down. Right? That's exciting. We've never had that in 118 years. And once again, I don't understand that, right? I mean, when we had the AIDS epidemic, within 10 years, we had treatment. Now people are living very long time. It's not a terminal illness really much for AIDS. But we've had this disease for 116 years, and this is the first time we had something that's actually going to alter the course. Seems a little weird to me, but that's what it is. We'll talk about the GUIDE program. It's not a disease, but it is a program. But in between there, like I said, there's really nothing. If you go from here to there, I think there's been very few advances in what's going on with Alzheimer's disease, right? Well, except for Alzheimer's Arkansas in 1984. They were there, and they're here to help you. So I think there are programs like that, Alzheimer's Arkansas, that can help you. So it is an exciting time. So there is good news, right? So there is good news, and I want to talk now about what we call the GUIDE program. Now, this is a government program that just started July 1st, actually. It's called Guiding an Improved Dementia Experience. It's from the Centers of Medicare and Medicaid Innovation. It's a trial project, and so the government says, we see the silver tsunami coming. What can we do to help caregivers? What can we do to help patients? And so this is a part of their plan. So this demonstration project is 8 years long, and after 8 years, they will evaluate it and say, do we want to continue this indefinitely? And hopefully they will. Hopefully there's success. And Medicare does this all the time. There's all kinds of projects. They'll test something for a couple of years. They'll get the data back and says, yes, that was beneficial, right? Yeah. So for a person to be in this program, you have to align yourself with a provider of this program, a doctor, nurse practitioner, a program. So that's important. You just can't call and say, I need to be in the GUIDE program. You actually have to be aligned with a program that's actually in the GUIDE program. People, when they come into the program, are on 5 different tiers that they'll fall in. So we get rated based on how severe the dementia is, and then also how severe the caregiver burden is, right? Here's the interesting thing. It is 100% free. There are no copays, no deductibles. And that's pretty rare in medicine. That does not happen. Most time if you have a program, you may have another insurance that pays what Medicare doesn't pay, but this is 100% free. And I think the big thing that if you want to be in the program, you got to be willing to work in that program. You got to be willing to do some of the things to help yourself and to help your people that you take care of. This is the model that they use. Really, this is what we want in all healthcare. Is you got the patient here and the caregivers, and we see that as a dyad, as tandem. They're working together. And all of these things, assessment, medical management, education, activities that they learn, the workforce, who can help me, all these sort of things are supposed to be surrounding the patient. And so this is one of the things that when Medicare designed this, with this in mind, how can we surround that patient with dementia and their caregivers with supportive services that can help that experience? So why would you want to be on this program? Well, you get 24 access to dementia-certified clinicians around the clock. You can call at 3 o'clock in the morning. You're going to talk to somebody, okay? Find out what's going on. Get some advice. That doesn't happen a whole lot. So that's one of the reasons. It's a requirement that you have 24/7 around-the-clock access, meaning phone calls. You can call and find out what's going on. No costs, no copays. Talking about respite earlier, this is other than outside of hospice. It's the first time that the government is actually going to pay for some respite care, okay? Meaning you can do it. It's going to be up to $2,500 that every beneficiary or every client will get up to $2,500 respite care, okay? Now, it's required that that respite care be in the home, okay? It can also be in adult daycare centers. It can also be like in a nursing home. But the government says, hey, you have to provide this service in the home. So like a caregiver could come in your home for 8 hours, okay, and let you do whatever. Or they could come in for 2 days or whatever. Or they could go to adult day center. Or they could go to the nursing home for the whole day. But that's pretty rare. Outside of hospice, I haven't seen where the government actually pays for respite care. You'll be assigned a navigator who will follow up with you on a regular basis. They're going to be calling every week, every 2 weeks. How's it going? Let's do some education. There's a transition of care. Oh, you need help? Oh, we need to find an assisted living, a memory care unit. Okay, let's help. They can help out with those type of things, what those resources are. Having problems with behaviors. Oh, okay, let's talk about how we can change those behaviors. What kind of things can you modify? So everybody gets a care navigator. This kind of comes out of the cancer world, right? Pretty much now, when I worked at the cancer center, everybody gets there's a breast navigator, there's a colon cancer, there's navigators all the time now. So that really comes out of this world of oncology, that when you have cancer, you need a guide, someone that can guide you through the cancer experience. And the same thing with dementia. We want to have someone that can guide you through the dementia experience. They also allow for up to $1,000 of possible home improvements, okay? Now, that's not a requirement, but the government really doesn't allow providers like myself to give you $1,000 to do that. They call that inducement, but that is a potential thing because the thing is they want to keep people at home. So if they can put a ramp, let's say, right, that may buy 6 months. Or they can do some stuff to the bathroom to modify that in some way. That may buy us some time. So what does it look like? So it's basically 3 things in the guide program. 3 big things that they're doing. Care coordination and management, right? Have an interdisciplinary team. They're working together. They're trying to coordinate the care, find your researchers. If they know, let's call Dr. Peppinger. Let's get you in to see them, right? Maybe one of these new drugs may be helpful, right? Coordinating that care. Support and education. Having someone you can call. Ask questions. They can call you proactively and provide education about what's going on, okay? And then the last thing is these respite services, right? So that's the core of the program, is those 3 things. How do you get on the guide program? So who qualifies for this program? Well, first of all, you have to have a dementia diagnosis. And it doesn't have to be Alzheimer's dementia. It can be dementia, you had a car wreck, and the patient now has traumatic brain injury. That qualifies. It can be vascular dementia. It can be Lewy body. There's a lot of different types of dementia. So it doesn't have to be just Alzheimer's dementia to get into the program, but you do have to have a diagnosis. And if you don't have a diagnosis, you can get a diagnosis, right? So our program that we're talking about, we could come, if there's questionable, they're confused, is this dementia? A lot of times we can come in the home and make that diagnosis and qualify people for the program. I think here's the kicker. You have to be enrolled in regular Medicare. Not Medicaid, not Humana, not United, not all those. It has to be traditional Medicare, because this program is only for patients on traditional Medicare, not Medicaid, Medicare Advantage, or any of those programs. They can't live in a nursing home, so you don't qualify if your loved one's in a nursing home. They can't be in hospice, and they can't be in a PACE program, okay? But outside of that, if you got a dementia diagnosis and you have Medicare, you're going to probably qualify for this program. What do we do? This is the care delivery model. So there's a comprehensive assessment. So what will happen is a navigator will either call you or come to your home and do an assessment. That assessment may be 2 hours long, looking at everything from hearing to behaviors, how doing interviews with you as the caregiver, how much burden, and forming an assessment. Then they'll start working with you as a referral and finding resources like, Alzheimer's Arkansas. That's a resource that we could refer to. There's a lot of resources in the community that you may not know about that may help you. Then we have a care plan. So what we have with that assessment, we develop a care plan. And we actually let you have that care plan. Like, hey, we develop a care plan. Here's the care plan. You get the care plan. We also send it to your primary care doctor or whoever to have that care plan, so they know what the plan of care is. We provide caregiver support, regular phone calls. That we've already talked about this 24/7 access. Help with medication management. They may not always write the medicine, but they may call the primary care doctor, or they may make recommendations for that management of that medication. Monitoring and support, care coordination, transition, patients, coming back from home from the hospital, or maybe they need to go to a memory care unit, or maybe they need to go to the nursing home, right? They can help with those care transitions. So these are the tiers. Remember I told you there was 5 different tiers that they'll fall in, and that comes from this assessment. When that care navigator comes in and does that assessment, it's divided between beneficiaries or clients or patients with a caregiver or without a caregiver. And if you have a caregiver, it's low, moderate, or high. Okay? Only these 2 groups right here get respite care. The moderate or high, you don't get it here, and if you don't have a caregiver, you don't get respite. So only these 2 groups get the respite care. So how do we decide who's in which tier? So when they come in, they're going to do something. The CDR is one of those assessments for dementia, or they're going to do a FAST score. And in our program, we're going to use the FAST score, and it has to be a 4 if it's low. And if it's over a 4, if you'll see here, it's a 5.7, 5.7. This thing here is called the Zaret Burden Interview. This monitors and measures how much burden caregiver. It's a caregiver burden measurement, okay? And so what will happen, they'll come in, they'll do a FAST score, they'll ask you 22 questions on a questionnaire and come up with a score. And between those 2 things, Medicare will decide which level of care you're in, right? So if your FAST score is a 3 and there's nothing, you're going to be here. Now, if you're here, you're not going to get the respite care. If it's a 5 and your score is a 60, or 0 to 60, you're going to be in the moderate category. And if it's a 5 to 7 here and the score is 61 to 88. Now, there's 22 questions on this with a score, and I'll show it to you in just a minute what that interview questionnaire looks like. This is the functional assessment score. This is what we'll use. If you're here and up, it's going to be low. If you're here down from 5 through 7, it's going to be high, okay, or moderate, okay? So if you're right here is the cutoff. Decreased ability to perform complex tasks like planning dinner, handling personal finances, forgetting to pay bills. That's considered low. If you go down here, requires assistance in choosing proper clothing, wear for the day, season or occasion, that's kind of the cutoff, right? So and this is called the Zaret benefit. That's not all 22 questions, that's only 13. It's rated from 0 to 4, right? So, and they're just asking questions about how well you are doing as a caregiver. government is looking at this program for the next 8 years to see how good it is, right? And they're looking at these 5 measures. They're looking at, are patients on inappropriate medications? A lot of older patients are taking a lot of medicine they shouldn't be taking. And there's a list called the Beers list. I don't know why they call it the Beers list, but it's called the Beer list. And I would, if you ever want to know, just type in BEERS, like beers, and it'll tell you every medicine that these geriatricians and dementia specialists have said patients should not be on these medications, right? And it's some stuff like antihistamines. Shouldn't be on antihistamines. It causes some confusion. I was actually on a phone call today. I actually looked at the Beers list with one of my patients, and digoxin was one of those medicines. So there's a whole list that's on there. They're also looking at the quality of life, right? Do we improve people's quality of life? And so they want to say, hey, with this program, is there an improvement in quality of life? And so there'll be a questionnaire that comes out every year asking about the quality. There'll be the caregiver burden measure. Are we reducing caregiver burden? They'll be looking at cost of care and then how many go to the nursing home. And their hopes is patients will be off the medicines they don't want to be on. They will not be going to the nursing home. They'll have improved quality of life, both the patient and the caregiver, right? Hopefully they're also saying, well, maybe they're going to cut cost as well. It's the government, right? They want to make sure. But some of that is not coming from they just want to cut costs. But if you're not going to the nursing home, 3 months, that's a lot. Or if you're not going to the emergency room because you have somebody you can call in the middle of the night, you're not going to go to the emergency room and get admitted to the hospital, right? So a lot of it's not just because we want to cut money. It's just like, can we be more proactive than reactive, right? Let's do that. So us at Arkansas Palliative Care applied. So in January, I wrote to Medicare, gave them our application to apply for this program. And so I found out 3 months ago we were approved for this program. So as I know right now, we're the only program in the state that's been approved for this year. From what I understand from Medicare, it was a one-time deal. You apply, and they're not going to, like next year, they're not going to ask for a new round. But they may change their mind. But for right now, that's kind of where it stands. And so our program, we've been taking care of dementia patients, so this is nothing new to us. I mean, I have patients I take care of in the memory care units. I got patients I take care of at home. So this is actually what the program was doing was stuff I was already doing, but I was doing for free. Nobody was paying me to do it. We were already doing it. So when I applied for it, I'm already doing these things. Like, we've been doing this stuff for 4 years. This is wonderful. We already know what to do, so that's exciting. So all of our clinicians, from navigators to myself, will be dementia care certified. Means they took a class, a course, did everything they need to be certified as dementia care specialist. We also have a dementia certified trainer from the National Council of Certified Dementia Practitioners. So there's not very many of those in the state, okay? So we have a person who actually will be training us and can train other people. Our idea is we're hopefully on our program, when it's fully operational, around 400 clients. So that's kind of what we're shooting for. Now, when we come up with that proposal, I did not know that there was not going to be anybody else in Arkansas. Now, there's 60,000 people right now in Arkansas with dementia, right? 60,000 people with dementia. So that was my original plan. We'll see how that goes, but that's what we thought about. It'll include navigators, social worker, an assistant, a manager, and our manager's right over there. Raise your hand. She's managing the GUIDE program. We'll have multiple nurse practitioners to support that team, along with the physician, which would be me. So this is the interdisciplinary team that we're talking about that will be available to you and to your loved ones. And we're really starting to take clients starting in August. We hopefully start in July, but the government didn't get all the stuff done that it should be. The portals and, didn't surprise us, right? So there's a lot of things that have to be done. And so we're going to be looking at this probably late August, mid to late August, to start to accept clients into this program. So what to expect? So what will happen is the navigator will either call you or come to your home, do an assessment. Then we have to give that to Medicare. Medicare says, yes, they are approved for the program. That's supposed to take hopefully less than 7 days, but that would happen. And then what will happen, you're going to regularly engage with that navigator. They may call every 2 weeks. They may call once a month, more frequently. Once again, you can call them at any time. Like during the day, the navigators at nighttime. We have our clinicians on call on the weekends at night. You can call for that. But they're going to be there to support you, provide educations, answer questions, right? I think one of the great things, and I've worked in hospice, one of the great things about hospice I've always heard is that you always have somebody you can call, right? So when patients are on hospice, you can call somebody 24/7 and somebody's there. Now, you call your doctor today at Christmas at 3 o'clock, what are they going to say? This is what my doctor says. If this is an emergency, call 911. If not, our business hours are Monday through Friday, 8 to 5, right? Make referrals of appropriate resources. They'll provide an educational booklet. This is a booklet we worked with a group who's a dementia specialist to develop for caregiver education. And then, once again, support groups, 24/7 access. So, that is the GUIDE program. It's called Through Arkansas Palliative Care. There's our phone number right over there if you want more information. They've got cards over there. Once again, we're looking to start this in August. If you feel like this may be a program, and pretty much we're in the Hot Springs area, so we cover Hot Springs area, we cover Little Rock, we go to Batesville, we cover Russellville, so we got a pretty big area that we're covering with this program. But what I'd recommend if you're interested, go right over there and pick up a card, and on that card you can scan it, like one of those QR codes, but it has the number and everything on that. So what kind of questions do I have? Tell us.
So what they define as a caregiver is anyone that is helping someone with their ADL. So when we come out and say caregiver, it means anyone that is helping a patient with their ADLs or their daily living activities. So I don't want to discourage you and think that that means you have to already have a paid caregiver or someone in your home. It is anyone that is helping. So all of you that help with those daily living activities are considered caregivers. And when Belle said 7 days, CMMI has told us that they can take up to 15 days to approve a patient. So.
I got it. Oh, well, yeah. I played pickleball last night. I'm hurting. My knee hurts. Y'all play pickleball? Who plays pickleball in here? I love pickleball.
Trust me, I won't need that.
Oh, you do got a good voice. All right.
Now, my question is, what if the dementia victim is VA?
It's not just for him, so it's for the people on the other side.
Here you go. Yeah, there you go. Here we go. There we go.
I'm a rule breaker, you know this. That's why we get along. My question is, if the dementia patient victim is VA, can they qualify for this program? I mean, he's on Medicare.
Yeah, I think as long as they have
But
Medicare, and
VA.
let me clarify, anybody with Medicare Part A and B should be on the program. Now, if you got Medicare A and B and VA, I would say yes.
Okay.
Clarify that even if like they have a TRICARE, because sometimes TRICARE will go over their Medicare, they don't have it, they just have to have traditional Medicare A and B.
Right.
How often is that respite available?
Unlike hospice where it's kind of defined, this is only defined by how much money. Yeah. Well, it's different for different things. So for in-home, it's 4-hour increments. So in the home, it's 4-hour increments. If you go to adult care center, it's 8 hours in the adult day care center. Or if you go to the nursing facility to have it done, it's a 24-hour, right? So that's, so you have to, the way that's set up for the in-home care, it has to be in 4-hour increments. It can't be 6 hours. So if you get what we're doing is contracting with personal care services to provide that.
Is it yearly, like that amount?
Yes, it's yearly. Right, it's yearly, and we keep up with it, so, you know, I figured up one day for a home, I think it's 11 days that you could get if you a whole day, like what they call 2 units, 2 8 hours. With how we're paying, the way Medicare's paying that, it would be like 11 days, I think, is what I figured it would be. What else?
Any other questions?
What? Range? Didn't have a map here, but we're from Pine Bluff, Hot Springs, Little Rock, Searcy, Russellville, Conway, even up to Batesville. That's the area we cover. And so basically, if you take Little Rock and maybe draw a map, maybe 100 miles around Little Rock, we're going to cover most of that. I wouldn't say all of that. You know, we're probably not going all the way out to Stuttgart or maybe, you know.
Yeah, you're going to Stuttgart.
Stuttgart, okay.
Summer, where
It's kinda-
else? Yeah, because she goes to El Dorado, you can do Murfreesboro.
Miles from CHI and Hot Springs. If you did 30 to 40 miles around the hospital, we will do that. If it's somewhere outside that area, reach out to us because we may be able to service this as well. Unlike hospice where they're defined in territories, if we have someone in that area, a provider in that area, we try to assist with that.
So what she really basically said, no matter where you live, contact them and let them decide if you don't fit in the area or not. Is that a good answer?
Right.
Okay.
$500 for the year, that doesn't mean that you aren't eligible for like other grants and other services, like Arkansas Alzheimer's, with their grant, you can use both.
What other questions we got? Well, thank you.
Thank you,
so
Dr.
much.
Bill.
Appreciate it.